Our next speaker is Dr. Jim Whittle, who's a medical oncologist at the Peter McCallum Cancer Centre. Dr. Whittle will go through the role of genomics for personalised treatment in brain cancer, current trials in Australia and overseas. Thanks very much, Jim.
Thanks very much, Marina, and thanks very much for the invitation to speak this morning on a really fantastic panel with Liz and Misty. It's great to be here with members of the Brain Tumour Alliance and the broader Neuro-Oncology community as part of the COGNO annual scientific meeting this week. Liz has given a really great introduction to what I'm hoping to cover this morning in quite a brief 20 minutes, but there's some material that I wanted to go through. So I'm a medical oncologist at Peter Mac in the Royal Melbourne Hospital and also a laboratory head at WEHI, where we've recently established a brain cancer research program with two other lab heads, Dr. Saskia Freytag and Dr. Sarah Best. So the focus of my talk that sort of follows on from Liz's fantastic introduction was, why do we need more clinical trial opportunities in brain cancer, and how can we work towards this cancer moonshot and dealing with, a really significant issue for brain cancer? In particular, I'm going to talk a little bit about the genomics of brain cancer, and specifically what is precision medicine or personalised oncology, and where are we at in the field for this at the moment? Hopefully helping you to answer a question: should I have molecular testing on my tumour, and what are the implications from this? And then a little bit about clinical trials in brain cancer. And Liz has introduced an important question that was posed to us about, should I travel overseas for a clinical trial? And we might be able to flesh that out a little bit more in the discussion. So I think often talks and papers in the field of brain cancer tend to focus on some of the negative aspects and the lack of progress over the last 20 to 30 years. But I'd much prefer to focus on, I think, what have been the significant developments and changes in science and care that have happened over the past 20 years. And a big part of this comes from an understanding of the biology and the science of brain cancer. I think we've also seen great strides in technology, in the fields of surgery, in radiation and imaging. There's been the development of a large group of national bodies, represented here by COGNO and the Neuro-Oncology community through the Brain Tumour Alliance and other groups. And these in turn have led to improvement in training, education, and building a specific workforce to target the problems in brain cancer, and ultimately leading to new clinical trials to change the field. Brain Tumour Alliance and COGNO have also played really important roles in advocacy and funding. And I think we're really starting to see, a critical mass, and this has been shown with the Australian Brain Cancer Mission and through the Medical Research Foundation, to lead to increasing funding to the field that I think we're just on the cusp of making some hopefully significant discoveries that will change outcomes for patients. But ultimately, even if we don't have new drugs, patient care has markedly improved over the past 20 years. And a big part of this is through a multidisciplinary approach, focusing on the treatment of disease-related symptoms and care coordinators and palliative care involvement that really improves quality of life. All of these have led to incremental improvements. So improvements in treatment, and I always start with surgery because I think surgery still remains the most important part of the majority of brain cancer care. We've seen significant improvements over the past 20 years, and Professor Kate Drummond, who's in the panel in the second half of the session, is really a leader in this, and these can include the use of awake surgery and bringing technology into the theatre, such as an intraoperative MRI and ultrasound to improve surgical resection. The radiation oncologists have also introduced new changes to treatment, for example, the gamma knife and stereotactic radiosurgery, which has enabled the delivery of more targeted therapy to hopefully reduce some of the long-term side effects from radiation treatment. But what about systemic therapy and biology, which is where I sit as a medical oncologist? I think it's useful just to turn to another cancer for some examples of what can happen if we understand the biology and the science of a cancer, and that can change how we treat. So metastatic melanoma, which is obviously a big burden in Australia, just 10 years ago was essentially inevitably incurable. However, through groups working together to understanding the disease biology, we've seen the development of targeted therapies and immunotherapy, and really looking forward to Misty's discussion on the role of the immune system in brain cancer later. But in melanoma, these changes have meant that now we are starting to even talk about cure for a large proportion of patients with metastatic melanoma. This really motivates me as a scientist and as a clinician to better understand brain cancer and therefore bring new clinical trials to the clinic. But it is important that we do acknowledge that in glioblastoma, the most common type of brain cancer for adults, in the last 30 years, there is only one trial of systemic therapy that has unequivocally shown a survival benefit. The Stupp protocol, which will be familiar to many people, established a new standard of care, but was only of modest benefit and hasn't changed since 2005. So we need new discoveries and new clinical trials to try and push this paradigm further. Liz gave a great introduction to the clinical trial pipeline and how scientific discoveries move through these phases, traditionally from phase 1, phase 2, and phase 3, and then hopefully towards registration. But noting that less than 1 in 10 of these agents will actually make it through to the registration phase. And unfortunately, in glioblastoma, nothing since temozolomide. And this has spurred a big field in not just brain cancer. An important sort of development over the last 10 to 15 years, not just in the field of brain cancer, but in all cancers, is precision medicine or personalised oncology, which, although is a very elegant concept, it does have complex implications. And this flow diagram on the left explains what I'm talking about in personalised oncology or precision medicine. This is where a patient will have their individual tumour, and we will remove the DNA and the RNA to try and understand if there's any particular tumour pathways which are disrupted. We can then compare these to databases, and then the goal is to identify particular pathways or targets that we might be able to treat with a drug. And then this drug can then be delivered to that patient, and ultimately we hope to lead to a better outcome. This is a great concept in theory, but I think often can lead to higher expectations than what is the reality at the current stage of development. And unfortunately, precision medicine does not apply universally or equally across cancer and also within cancer types. And there's a significant issue regarding equity. And this relates to the financial toxicity of both doing the testing and also ultimately accessing the drugs, which can be quite complicated and tricky. And finally, although this is a great concept, there is a lack of data for widespread clinical implementation in brain cancer currently. But that really means that we just need to keep pushing the field forward, both with the community and in our laboratories and clinics. So this brings me to an important question about precision medicine and personalised oncology. Why should you order a genomic test? So the most important and first is when I think about this is to identify a treatable genomic result. And this is what we would refer to as a predictive biomarker, where we can find a result that would then identify a matched treatment option. But similarly, a biomarker might predict resistance and tell you a drug that you shouldn't use, whether that's a standard of care therapy like chemotherapy, or whether it's a novel therapy that's being tested in a clinical trial. These biomarkers can also be useful in helping us predict outcomes and be able to give patients and their families more information about what the future might hold. And these prognostic biomarkers are all just as important as predictive. We can also understand better about where a cancer might have started, and that will help us decide on what the best treatment might be. And finally, although this is really in a nascent phase for brain cancers, these genomic tests can also be useful to monitor treatment response and help us predict what might the next treatment option be. And there's a lot of information that goes into determining whether a particular gene is a cancer gene, okay, is associated with, the development and the progression of cancer. And this is informed by a wide variety of evidences, right from laboratory studies or preclinical evidence, through to clinical evidence from patient testing and clinical trials, or the patterns of mutations that might come together. We also have learnt a lot about cancer from studying cancers which occur in families, and the BRCA1 and BRCA2 genes associated with breast and ovarian cancer are probably the two most well described and understood. All of this feeds into large databases, and more than 500 and up to 1,000 of genes can be associated with cancer. But before you go about talking about genomic sequencing, and these are the things that I like to consider in discussions with patients, is what do you need to think about first? And number one is, what do we already know? And what that indicates is that standard of care testing in the clinic, what is routinely done by pathologists, already gives us a lot of information both about predictive and prognostic biomarkers. And some of these names might be familiar to you, such as mutations in IDH or MGMT methylation, which are routinely used. Second question is, what are we looking for? And to know this, we need to understand the genomic changes which are common in brain cancer, which is beyond the scope of my talk this morning. And then thirdly, what test should I choose? And that requires an understanding of what are the requirements for testing, and also what the limitations for testing might be. This flow diagram gives a bit of an understanding of what actually might happen to a tumour sample or blood sample to do a genomic test. And as you can see, we can do genomic tests both on tumour samples that are taken at the time of an operation or a biopsy, or increasingly also what we would refer to as a liquid biopsy. And that might be blood, saliva, even cerebral spinal fluid, even urine can give us information about a cancer as well. And these tumours are usually fixed in formalin and then looked at under a microscope by a pathologist. They look at the protein by doing immunohistochemistry. And this information, or these slides, can then be used to extract DNA, or we can snap freeze a tumour in liquid nitrogen to preserve the DNA. Cancer cells can also escape from the primary cancer site and enter the blood. And this is currently in a research phase for brain cancers, and we can extract DNA in these forms for genomic testing as well. And over the past 10 years, there's been a huge boom of different types of commercial testing platforms, both available here in Australia in an academic setting and also commercial setting. And it is important that we acknowledge there is money to be made here, and that means there is significant commercial involvement. And before deciding on what test to do, the clinician, in discussion with the patient and their family, needs to describe the multiple types of testing, the cost, which is significant and can range between $2,500 and $7,500, and a significant turnaround time to actually get the result. And finally, where might the extra support and independent review be to help predict what the information comes out on the other side? And ultimately, what tests to order depends on what we're looking for. And this ranges from a whole scope just by looking at a single gene of interest, or several genes, or a panel of genes that can be up to hundreds, through to looking at the entire genome. And depending on what test to order, depends on what you are trying to achieve and what you're trying to learn from that test. And generally speaking, in the clinic, we're probably on this side of the equation using small panels or single genes, which are targeted questions where we really know what we're looking for, as compared to doing a whole genome study, which is slower but gives us more detail, and typically at the moment is more restricted to research use. And the results might give us different types of information, and that may or may not be relevant to cancer treatment. And this is a concept of what we call passenger and driver mutations. And passenger mutations are those mutations which don't drive cancer initiation progression. So they're really unrelated to the cancer development and are just a biomarker of the genomic instability that happens within the normal setting and particularly within cancers. And this compares to driver mutations, and these are the ones which are really important. These are the mutations which drive the initiation and progression of cancer and often the resistance to treatment. And this is where we want to ask the question, can we switch off these mutations and pathways with a targeted therapy or drug? But again, what do we need to consider as well before going ahead? I think importantly, the test might not work, and about 10 to 15% of these genomic tests will fail. And still, although as I said at this outset, this is a great concept, in the majority of patients, it's not going to actually change treatment decisions. And it may help, but in the majority of people, it's not helping. It also might create a lot of frustration and stress by indicating a treatment which is not yet available in Australia. Or if that treatment is available, it can be associated with significant cost, up to hundreds of thousands of dollars. It also might indicate hope with a treatment, but that has limited evidence of benefit in brain cancer. And the findings might also have implications for your family's future cancer risk that are important to be discussed as well. So where are we at for targeted therapy in brain cancers? And I just put in 2 examples here because I think I can't cover all of these. But these are 2 examples of mutations which can happen in brain cancer and other types of cancer. For example, a BRAF mutation, which happens in about 1 to 50% of brain cancers, and we can treat it with a particular target, called a BRAF inhibitor. But this doesn't, just because you've got the mutation, doesn't mean that it works in everyone. So only about 20 to 30% of patients will receive benefit from the treatment. Similarly, there's a newer type of mutation which people are talking about called NTRK, N-T-R-A-K, where these mutations are less frequent, and responses for patients who have brain cancer, these mutations are in the order of 50%. And what we need to be developing as a community is really trying to understand how we can find the people who are going to benefit, how we can enhance testing, and so that we have more equitable access to genomic testing across patients and all types of brain cancer, so that we can find those people who are going to derive the most benefit from treatment. And just switching tack a little bit more to clinical trials now, and Liz really gave a great overview of trying to balance the risk of hope for response and benefit from a treatment versus the potential toxicity. And toxicity is not just what the drug might do, but it's the burden of coming to lots of appointments and additional follow-up that you might not have in standard of care. And in terms of Australian brain cancer trials, the COGNO is really leading the development of brain cancer trials in Australia. And this is by bringing large groups together across Australia so we can put as many people on possible and really understand the science and progress the field forward. And COGNO has led a number of phase 2 and phase 3 trials over the past 10 years, which have been practice changing. And these include the Cabaret, the Virtu and the Nutmeg study, and currently the Magma study, which is using a really novel design to enrol patients across Australia and answering important questions in the field. And we also have a large number of sponsored trials, and these are typically funded by biopharmaceutical companies investigating the new drugs. And at this stage of development, we're really looking mostly at phase 1 and phase 2 studies, trying to identify new targets and new treatments. And so typically these occur in large referral centres and may reduce access, as Liz has indicated, for patients in rural, regional and remote settings. There's also been significant development in precision medicine trials. For example, the MOST platform, which is led out of St Vincent's and the Garvan in Sydney and is across Australia now, is really trying to push the envelope in the form of personalised oncology, where patients' tumours are tested through these sequencing platforms that I've described to try and identify if there is a drug or an immunotherapy that might benefit our patients. And these options, and this is really improving access to both not just the testing, but also access to new drugs. And I'm really hoping these types of trials will continue to increase. What about travelling overseas for clinical trials? And as a clinician, these are questions that are often asked, and we often have discussions. I think there's some important things to consider. And again, beyond the scope of this talk or the discussion to answer any specific questions about specific clinical trials, but these general points are important. Most will be experimental. And I think we do need to remember that, not all drugs that are tested in phase 1, and the majority are not going to make it through. But obviously, there will be some. We always need to be aware of the hype and the N=1 story. That is the outcome that someone tells you about a friend or a colleague who had a great experience, and therefore this is the only option for you. We need to remember that ethics review is not standard across the world, and the rigorous human ethics committees that happen locally in Australia are not always consistent. And there is a significant opportunity cost, not just the financial cost, but also being away from family and supports. We also need to be aware that sometimes you can access drugs which are available overseas without actually going through compassionate drug access programs as well. And pharmaceutical companies working with clinicians and patients are doing this more and more. Liz gave a great slide and it's more information about where to go, but broadly speaking, emphasising that it's best to speak to your oncologist and other treating team members. And you can get information from clinical trial groups. Brain Tumour Alliance has a great web page and resource list for clinical trials, and there's other websites that you can look to. The reason why it's always great to go back to your oncologist is sometimes this information is not completely up to date, and it's not clear that it's particularly relevant to your setting. So in summary, there's been significant developments in the field of brain cancer, and our understanding of biology is going to continue to guide new treatments. But currently the science has probably outpaced our drug development, and there are still issues with access, which is not equitable. But ultimately, clinical trial is good medicine. It provides opportunities, there's rigorous monitoring and care, and it does help move the field forward. But this isn't for everyone. Not everyone needs to go on a clinical trial to get great care. And I think that's also really important, that the care that you're going to get as standard in Australia is first class and is as good as you get anywhere else in the world. So with that, I'm going to finish and look forward to answering questions later in the discussion.